on CKD without the confusion. So covering kind of latest guidance and best practice and bring it to life with case studies. But before he does that, I just wanted to take a minute to tell you about Practiki, which is our micro-learning app. And I wanted to check, does anybody currently use Practiki? Has anybody heard of it?
I'm going to have to say yes, aren't I?
Okay.
I do have it.
At least, oh, brilliant. Okay. So Practiki is a micro-learning app that helps GPs and actually the wider primary care team as well to keep up to date with all the latest guidance and evidence and best practice, and also earn CPD points. The idea came about when my wife, who is both a GP and a busy mum, was struggling to find the time to fit traditional CPD in around everything else. And as well as being a GP, she's also German, and I was trying to learn German on Duolingo, a micro-learning app for language, and we thought to ourselves, why has nobody done this for medical education? So we wanted to try and do for medical education what Duolingo did for language learning. So make it mobile first, interactive, bite-sized, so that it can fit around GP's busy schedules. So we launched the app last year. We've got an editorial board of about 15 expert GPs, all with different extended roles, led by Dr. Tony Hazel. Some of you might know, she's a Deputy Director of Relearning at the RCGP, and they create or have already created hundreds of microlearning modules, and we publish a new module every day. And all the modules, they're interactive clinical cases, they're quizzes, they're podcasts, all designed to be completed in 5 minutes, all tracked for CPD. You can download your CPD certificates, but for those that use 14 Fish, it can also connect straight up, so the learning flows straight in. We've just got over 11,000 primary care users in the UK, and I'll share a link in the chat. But if anybody hasn't come across Practiki yet and wants to give it a go, you can sign up today using the links that I'll share and a referral code, so staff05, and that'll give you free lifetime premium access. But what I thought I would do, if I can share my screen, is just show you the kind of the micro learning in action. So could you just shout when you can see? Hopefully, you can see the app.
Yeah, can see it.
Perfect. Excellent. So I'll start by diving into a case. I thought we'd do one on CKD. So the whole idea with Practiki is it's very practical, it's very interactive, and it's all based around clinical cases. So you get some information about a patient. So Mrs. Smith, in this instance, 58-year-old woman visiting a GP practice and requesting a routine health check, reports generally feeling well. You get a little bit of information, so on the medical history. And then there'll be some kind of interactivity, and that could be an open text question like this, a poll, an MCQ. Mrs. Smith's history. So what would prompt you to screen for CKD? And you put the answer in here. And then, so Mrs. Smith's risk factors, so based on her history, NSAID use and previous AKI. And then you get a little bit of education around the different risk factors. Bit around screening based on the latest NICE guidance. And then you'll have some other kind of interactivity. So for example, here, all results came back normal. Would you be satisfied with this information? So this is a poll question. There's not necessarily a right or wrong, but as a user, we want you to stop and think about what you would do in this situation. So let's say yes in this instance, and we show you what your peers on aggregate have done. And we've had a few thousand completions of this module, and there's quite an interesting split. Around a third would be happy with this information, 2/3 wouldn't. And then the case moves on. You get some education about CKD screening, again, all referenced up. And now you've got your first MCQ. So how would you explain the results to Mrs. Smith in this instance? So I'll, let's say B, I don't know the answer. So I got that wrong. Interestingly, the answer is C there. So about 40% said A, the rest said C. And so you get the idea. The whole idea with these cases is they're very interactive. It's trying to bring to life the latest guidance and evidence of best practice around a case study that you may see in your practice, and then it's all logged for CPD. So I won't do the whole thing just in the interest of time, but that kind of brings it to life. This is what the app looks like. You've got a new module every day here. This was developed in collaboration with Cancer Research UK. And then you've got these feeds of modules, a little bit like YouTube or Netflix, that are recommending information and different modules based on what we think you'd be most interested in, to try and keep you up to date. And then lastly, we've also launched in association with NICE this Ask a Clinical Question feature. So the idea here is, if you've got a specific clinical question and you don't have time to go to the NICE website or GP notebook, we've got every NICE guideline and about 3,000 or 4,000 other clinical guidelines in here. And you can ask a clinical question. So, for example, how do I diagnose CKD? And it will instantly go into the sources. So here it's found the NICE quality standard, NICE clinical guidelines, and it's pulled out the answer for you, so you don't actually have to go digging around hundreds of pages of guidelines. At any point, you can dive into the source, the full reference, if you did want to trawl through the NICE guideline to double check the answers. But the whole idea, again, is just like we're trying to save time with the micro-learning, we're trying to save time by giving instant answers to clinical questions. And you can ask follow-up questions here as well. So, yeah, very whistle-stop tour of Practiki. If you haven't given it a go, I'll share some links in the chat, and also provide a flyer that can be circulated afterwards. But yeah, we'd love you to try it. Please feedback. We're a very new company, only launched last year. So if anyone has any ideas, either for content or product features, we'd love to hear from you. Happy to take any questions if there are any. Otherwise, I'll hand over to Zen for his session. Okay, in which case then, Zen, over to you.
Thank you very much. Thank you.
Thank you, Matt. Sheena and Luis, can I just ask something? Obviously, interactivity is a bit limited, but would you be able to feedback to me any answers or any questions that pop up in the chat while I'm doing the presentation?
Yep, absolutely, no problem.
Excellent, thank you. So let me just start sharing everything. Fantastic.
I think there was a question in the chat about the code, but I think that's for Matt to put in about the code for Practiki. Is that right in the chat?
Yeah, I'll drop that in shortly.
Perfect, thank you.
And can I just check, we're seeing the presentation with the Primary Care Cardiovascular Society logo on the right, am I right?
Yeah,
Yes.
perfect.
Excellent. So thank you everyone for the invitation to come and speak through this PTL. I'm Xenophon Gassianidis, but after 16 years in the UK, I go by Zen. I'm a general practitioner with an extended role in CVRM medicine and an honorary clinical lecturer. Today, we're going to talk about CKD in primary care, and more specifically, how to remove any confusion that exists around it. CKD appears everywhere, really. We deal with it daily. It's in the blood results, in the searches that we do in medication reviews. But it seems like there's always a degree of uncertainty when we talk about CKD. I wish I could take all confusion away, but nephrology is always a difficult topic, and my aim today is not to turn any of us into nephrologists. My biggest aim is actually to just give a bit of structure, really, when it comes to CKD. So these are my declarations of interest. It's important to say that this is an unsponsored talk as well, with no influence on the content of the slides. So by the end of the session, I want all of us to feel more comfortable with 6 things. The diagnosis and the coding of CKD, because mislabeling really creates a lot of anxiety both to us and the patient. Secondly, knowing why ACR rather than when ACR really matters, because the whole notion of proteinuria and albuminuria is what guides a lot of what we do in terms of risk management. How we can hit any quality of framework targets, and then a bit more about using the kidney failure risk equation, which can help us with clinical judgment, knowing when and who to refer, and finally, very, very importantly, what our patients actually want to know. Because I can guarantee that none of our patients will come and ask us what's the difference between G3A and G3B. They're more probably to ask us, what does it mean to me, and am I going to need dialysis at any point? So why CKD matters really. We need to just zoom out and go on a bird's view and look at our typical practices. We've got a prevalence of around 10 to 15% in UK of CKD. Most of our patients have no symptoms at all, so it's a silent condition, and importantly, it is modifiable. Progression of CKD, the risks that come with CKD can be reduced. And this is the one thing that we need to think a lot about in primary care. It is more about risk management and mitigation rather than about thinking who and when will reach dialysis. Also, our parents will never reach dialysis. However, the risk for cardiovascular morbidity and comorbidity is significantly higher. So we need to gear it up, if you see what I mean, and think about how to treat that assertively any comorbidities that come with CKD. So NG203 in 2021 was a much needed update in relation to chronic kidney disease. And in reality, everything that we need to know in primary care about CKD diagnosis is summarized in this slide. The important thing about the NG203 is that it was a more consolidated and more comprehensive version of previous guidelines. It appeared to be more equitable in that it removed ethnicity adjustments from anything that we do, and then it was broader in scope. So it didn't only go about adults, and that's with CKD in adults, but it also talked about young people as well in the slides, in the actual guidance. So our next step is to think about a case. And I was thinking about Mr. Ali, who's a 72 years old gentleman, who's a very independent and active member of the community, who, however, over the past 2 decades almost, he's been suffering with type 2 diabetes and also with high blood pressure. He frequently has come to the general practitioner to inquire about his osteoarthritis of the hip and what steps we can take to make it forward. He's on certain medications already, so ramipril, amlodipine, and metformin. So my question, and this is where I rely to Sheena and Luis, is, and just hands up or thumbs up, how many of you would already start thinking about this patient as someone that could be having chronic kidney disease? Sheena? Have we had some thumbs up?
Yeah, we've had some thumbs up. Sorry, I wasn't counting how many thumbs up.
No,
Sorry,
don't worry. I just need it. Excellent. So, and you're right. Actually, this is exactly the kind of patient that hides in plain sight. Long-standing diabetes, long-standing hypertension, already on some pillars of management, but it's not someone necessarily that we looked already in the past to think about CKD, to think about urine ACR. And in reality, that may make us miss progression. And it's important to, before we even look at numbers, to think about the patient that we have in front of us, the phenotype, I would like to call it such. And indeed, a reference to my original...
Sorry to interrupt. We've
yes.
got a question, a hands up from Mel Gray, I think.
Yep.
They want to speak.
Sorry, he said hands up or thumbs up, so
sorry,
I did a hands up instead.
Don't worry. Don't worry.
Thumbs up or hands up, it would be the same at the moment.
Sorry.
I wasn't sure if it was a question. Don't worry. Don't worry.
So, going back, as we were talking, that slide and that slide only that NICE came up with actually summarizes the patients that we really need to pay attention to. And it's the patients with diabetes, with high blood pressure, patients that have had AKI in the past, like the example of with cardiovascular disease, patients with multiple diseases that could have an effect on kidneys, so things like systemic lupus erythematosus, or patients that are indeed on certain medications, and then patients that frequent use of certain medications that could be associated with acute kidney injury. And more specifically, we're thinking about non-steroidal anti-inflammatory medications. Then we've done some bloods on Mr. Ali, and indeed what we find out is that his eGFR is 58, creatinine a bit high, obviously adjusted with his overall weight. And then we see that his lipids as well, the LDL is a bit high. HDL is a good HDL, but there seems to be an element of hyperlipidemia in that case. We could talk already about the management just by seeing this, but for the interest of our chat about chronic kidney disease, it's important to think about the next step. And the next step really isolates the fact that an eGFR of less than 60 on its own does not indicate chronic kidney disease. If anything, chronic kidney disease needs to be chronic. And hence it's important to repeat the eGFR within 2 weeks to exclude acute kidney injury. You could argue, of course, in the case of Mr. Ali, would you really need a repeat 2 weeks later? Or we know the capacities that we have in general practice. Could that happen in a month, for example? And in reality, provided that there's nothing pointing to the direction of acute kidney injury in his history, then it wouldn't be unreasonable to repeat it in a bit of a longer time period. The other thing that's really, really important to do, and we tend to forget about it in primary care, is the importance of urine dipping. And not so much about protein per se, because anyone with CKD, I want you to think albumin-creatinine ratio automatically. It's very, very important to identify the potential for hematuria. Because hematuria can either mean most probably a post-renal cause, or even more importantly, in terms of nephrology, an intrarenal cause. So what actually counts as CKD? CKD is abnormal kidney structure or function for at least 3 months. And it has to have certain implication. It either has to have an eGFR less than 60 for more than 3 months or persistent albuminuria. It's important to say, like we said already with Mr. Ali, a single eGFR of 58 does not equal CKD. And at the same time, someone with an eGFR of 75 that has an ACR of 25 again and again, it doesn't mean that they don't have CKD. So chronicity matters, but also thinking of both components of what we think about when we talk about chronic kidney disease. We repeat Mr. Ali's blood tests. And in this case, we see that eGFR, it hasn't massively gone up, but it's still 56, so under 60. We've done a urine ACR because we are familiar with the NICE guidelines, and we are thinking now that we have a patient with chronic kidney disease. When it comes to chronic kidney disease and its staging, how many here are comfortable with what every letter next to everything means? So when we say CKD2A or CKD2A, or CKD3BA1, any idea? Everyone is comfortable with that? Or if not, again, a sign of thumbs up. We will move swiftly to the next slide, which is about CKD staging. So Sheena and Luis. Okay, let's move on.
I think this is a general thing that everyone needs to use the charts because we can't keep it in our heads. So.
Fine. So, pardon?
I think there was some background noise from someone else's. They've muted now. So
CKD staging without a headache. So in reality, when we think about chronic kidney disease, we think about filtration, and that's represented by the eGFR. And then we're talking as well about leaking, and the leaking is what comes from albumin. In reality, the G is the stage, and the G is the stage in relevance to filtration. The A is the stage in terms of damage. And the risk increases diagonally across the grid. So we start with the green, and then we move forwards and forwards towards the red. In reality, someone with G3A1 is actually at low risk compared to someone at G3A3. And that's interesting because even though they have the same eGFR, if you think about it, albuminuria is what drove their risk to be higher. The numbers in the grid itself are a clarification of how often we would like to repeat their eGFR in a year and their urine ACR. And this slide is can be found in the KDIGO guidelines, which are the governing body when it comes to kidney disease in the world. So if we need to remember one thing and one thing only from this grid is the fact that the eGFR tells us how much kidney function is left, and then ACR tells us all about leaking. And leaking kidneys are the ones that get into trouble. This is the evidence of stress on the kidneys. And that's why there's only two things that I want you to remember as a rule from this presentation. One of it is ACR, and then the other is risk management. And talking about ACR, it's important that we get ACR properly done. If we don't get it properly done, it could lead to a number of unnecessary referrals. So ideally, it needs to be an early morning sample. It should be not during UTI or acute illness and not after heavy exercise. Any abnormal result, even though the guidelines, the NICE guidelines say above 70, you can act on it already, I would advocate for it to be repeated because the language we use to the patients is very, very important in order to make sure that they're doing it right. In certain cases, such as fever, infection, very poor glycemic control, we might see some transient albuminuria. So it's important that we do the urine ACR properly. A lot of the times we see patients with catheters, and the common question is, well, is urine ACR really appropriate for someone with catheter? Yes, provided, again, it's done properly. And for it to be done properly, we would be talking about emptying the bag, disconnecting the bag, putting a aspiration device on the stomach of the bag, and then just doing a clean catch of urine from that point of view. So urine that stays in the bag, especially if it's overnight, should not be used for urine ACR purposes. So we are looking at the trends of Mr. Ali. We are seeing that his blood pressure could do with a bit of work. His diabetes, not unreasonable. And then we see this eGFR picture that we've talked about. And that leads to the next stage. We've already thought about the fact that Mr. Ali has chronic kidney disease, and more specifically, if we were to go a step back, we would class him as CKD 3A1. So we are already aware of his chronic kidney disease, but so what? And this is really the pivot point in this presentation. Why is it important that we know about his chronic kidney? Is it because of what medications we can give? Is it because we can avoid any future implications? What's the one thing that we need to start thinking about? And indeed, once we have CKD diagnosed, our management changes a bit. And in a way that we suddenly need to think about all of our cardiovascular risk factors a bit more intensively. We need to think about the blood pressure. We need to think about the medications that they're already taking for that blood pressure. We need to think about their diabetes status. Is there anything missing from their current medication list? I'm not an advocate of polypharmacy. However, as you all know, the new NG28 guidelines for diabetes have come out, which have changed a bit the pace in which we address diabetes. We have to think about their global cardiovascular risk. What about their lipids? But also we need to think, is this patient someone that I can safely manage in primary care? And is this someone that I will need to pay particular attention to as he remains one of our patients? Without any label, if you think about it, we might not have any prevention ongoing. While with the label, it makes us think about being more into a structured prevention sort of mode of action. It is not about coding for coding's sake. You all know that in reality, with regards to chronic kidney disease, other than having an annual CKD register, there's no allocated points for chronic disease. More than anything, it's about activating prevention in these patients. And this is the other slide that I was already referring to about the patients and about what I would like you to memorize other than ACR. So this is again borrowed by KDIGO, but it is very, very well reflected in the NICE guidelines with the exception of the blood pressure target, in that it is very, very important to think about SGLT2 inhibitors, even in the absence of diabetes in someone with albuminuric CKD. It's important to think about their blood pressure control. Ideally, the lower, the better. And then, of course, it's important that we minimize their risk of having any further cardiovascular disease. And indeed, as part of the cholesterol curves, CKD is one of the target populations where a discussion about lipid-lowering therapy should take place. In reality, with regards to the follow-up of the patients, that's dictated by the stage of CKD they are already on. And there are ways of risk calculating, which we will come to very soon, which could aid us in any discussion aid that we have with our patients, but be in relation to how we follow these patients up. So, bit of a busy slide, but really a summary about the 2 medications that are already licensed in the UK in terms of chronic kidney disease management that we have now more readily available in primary care. And it's important that we stand on the topic of proteinuria because, as you remember, the one thing that drives damage the most is the protein, and that's the sign of damage, the leaking. And that's why proteinuria in its own makes us start thinking about doing something about it. So, as you can see, on one side of the slide, we have the ACE inhibitors, the ARBs. They can be started in patients without diabetes, in anyone with ACR between 30 and 70, and they can be started in anyone with an ACR over 70, but also with a consideration about referring this patient. In patients with type 2 diabetes, we should be offering ACE inhibitors really above the ACE of 3, especially in the case that they are hypertensive. I've mentioned ACE inhibitors. In reality, though, the medication that a lot of times we go for that also alleviates regarding ethnic minorities, age as well, is that of ARB, so losartan, candesartan, that class of medications. Now, SGLT2 inhibitors, really the relatively newer kids on the block, initially diabetes, then heart failure, and then, Lord behold, kidney disease as well. So, NICE advocates that where ACE inhibitors or ARBs have been optimized, and unless there is any contraindication, so any predisposition to euglycemic ketoacidosis, for example, then we should really start thinking about SGLT2 inhibitors. And in reality, dapagliflozin and empagliflozin are both currently licensed in the UK for use in patients with chronic kidney disease. And depending on their eGFR, the dosing is adjusted. We should be ideally offering this to any patient with type 2 diabetes and an ACR of 30. However, NG28, like I was mentioning earlier, that goes off the window. Any patient really with CKD and diabetes, we should be thinking about SGLT2 inhibitors relatively early. When it comes to SGLT2 inhibitors, however, and their diabetic controllability, it's important to know that below an eGFR of 45, this is getting significantly reduced, and then below an eGFR of 30, any really hypoglycemic effect is gone. And then, like we said, there is a change there with regards to the guidelines that were only published last week. And then we talked about blood pressure.
Sorry to interrupt you, Sam. I've been trying to speak quickly. I can't get in there. There's a question from Dr. Holden about whether you needed a meat-free sort of period before sampling for your urinary ACR.
Not ideally. So I wouldn't say that you need to, I wouldn't advocate to the patient to have a heavy protein meal the night before, but I wouldn't expect it to be the cause of a single isolate. Sorry, I wouldn't expect it to be the cause of repeated urine ACRs that have been raised. And that again highlights the need for repetition of urine ACR, especially in patients, which are the common ones that we see, those ACRs of 10, 15, 20. Obviously, we're talking about an ACR of 70 and above. It would be highly unlikely that the only thing that drove that is a heavy a heavily meat-fuel diet, and it would be a matter of actually seeing the patient, talking to them, and making sure there's no hematuria, and talking to our colleagues in secondary care.
Okay, and there's another question as per the slide.
Yes.
Rabbi, I don't know if you want to ask it, because I don't know if you can access your mic if you want me to read it out. You may not be able to access it. It says, as per the slide, we only add ACE if ACR over 30, if no diabetes mellitus, and we don't consider adding the SGLT2s unless patient is having ACE. Is that the correct interpretation?
So, yes and no. It is correct about the fact that NICE guidelines would not offer a ACE inhibitor for someone that has no hypertension or diabetes below an ACR of 30. Realistically speaking, how many of our patients that have chronic kidney disease do not have high blood pressure or do not have diabetes? So in reality, someone that has high blood pressure already, it would be ideal that they're either on ACE inhibitor or an ARB for maximum renal protection. Now, SGLT2 inhibitors. Now, if they have CKD and type 2 diabetes, they should anyway now, with the new guidelines, be on an SGLT2 inhibitor as part of their hyperglycemic control. In reality, there's always there's always possibility in when do I start medications, how do I follow them, and when is someone really on an optimized ACE dose. We're all healthcare professionals in primary care. We know how limited our time is in terms of bringing patients up repeatedly for up titration of medications. So in reality, I would say that any proteinuric patient with a relatively good eGFR of above 20, above 22.5, SGLT2 inhibitors should be in our minds, whether they can have tolerated, whether they've accepted, whether they've needed to be on a RAS inhibitor. Does that answer the question?
I think so. And I had a follow-up question actually. What happens with the patient that just keeps getting urinary tract infections when you put them on your SGLT2?
So, if we look at all the evidence, I'm talking about systematic reviews and meta-analysis, there is no potential signal that has to do with urinary tract infections, pure urinary tract infections, so bacterial, and SGLT2 inhibitors. Indeed, there is increase and there is a safety signal there about mycotic infection, so candida most commonly. That is a tricky situation where we have to balance, really. We have to have an honest discussion with our patients, and we need to see how we can reduce the possibility of getting such infections. The MHRA bangs the drum a lot about the possibility of having Fournier's gangrene. But if we look at the chances of developing Fournier's gangrene in the adult population of the United Kingdom, we're talking about something, if I'm not mistaken, to 1 in 300,000 cases. Similarly, if we were to look at the evidence from the studies that we've had in front of us, so DAPA, CKD, EMPA, kidney, and also the ones relevant to diabetes and the ones relevant to heart failure, the true incidence in terms of Fournier's gangrene compared to what we would expect the background population to have. So don't think about a comparison between placebo and SGLT2 inhibitors. Let's just think about a situation where we're comparing background population and patients on SGLT2 inhibitors. In reality, there was no significant difference between the people that have Fournier's and that receive SGLT2 inhibitors and those that are in the general population. Now, of course, Fournier's gangrene is a terrible condition, and it's something that has been noted in studies. So it would be heavily unreasonable not to inform our patients about Fournier's gangrene. But what I would say is I wouldn't want to demonize SGLT2 inhibitors and brand them as either UTI-prone medications or indeed, more importantly, Fournier gangrene-provoking medications, if you see what I mean. It's really, really important as well with SGLT2 inhibitors to always remember that the rules for sick days apply, and it's really, really important to be able to articulate that to our patients and to know that they will follow it. Frailty, for example, which is particularly common in practice, and also a particularly common comorbidity with chronic kidney disease, makes our job as their clinician even harder. And that's where we need to know what the medications do. And then we also need to be able to offer a more tailored plan to our patients. So what I want to highlight is that there's a heavy need for personalization, especially when it comes to chronic kidney disease. It's not a blanket rule because A, we need to think about polypharmacy, and B, we need to think about the side effect profile of any medication indeed we prescribe. Does that answer the question?
That does. Thank you. Sorry, it's a difficult question.
Excellent.
Sorry, thank you.
No. Thank you, Sheena. So we were talking about blood pressures. And that goes again to what we said already about NICE. Because remember, NICE is cost effective, not necessarily best practice in terms of what can be adopted. NICE guidelines suggests that in patients that have chronic kidney disease, but they don't have protein in their wee, we can have a blood pressure that's below 140/90 in clinic. However, in patients that are heavily proteinuric, so we're talking about more than 70, or in patients with diabetes, indeed, we would need to have a bit of a lower threshold. Interestingly, KDIGO, which we've talked already about, which is the organization that oversees kidney care globally, advocates a blood pressure systolic of less than 120. However, the British and Irish Hypertension Societies, in more of a pragmatic view, they've suggested that a systolic blood pressure less than 130/80 in patients with chronic kidney disease, or the lowest blood pressure tolerated, would be amenable and would be suitable for our patients. Because it is important to think that blood pressure is actually one of the biggest modifiable drivers of CKD progression in primary care. The big ones are diabetes and blood pressure, from what we can do as their doctors and their pharmacists and their advanced clinical practitioners. So that's the ones we need to target. That alongside polypharmacy. And it's important, and it leads to the point that we've already made. It's important that we individualize. In the frail elderly patients, really, we need to avoid overtreatment. We need to avoid symptomatic hypotension. We need to avoid dehydration and falls, because kidneys love stable perfusions. Kidneys don't like to be aggressively swung all over the place. So if anything, if we control the blood pressure well, then we prevent any progression. And then we talked again about the cardiovascular risk, that it's important that we make sure that we deal with that cardiovascular risk. CKD is a stage of microinflammation and raised oxidative stress. As a result, their chances of developing cardiovascular disease becomes greater. And indeed, patients with chronic kidney disease, their number one killer is cardiovascular disease, whether they are on dialysis or they're not. Any patient really with CKD should be offered an atorvastatin 20, and then have the discussion as well about what being on a statin means, or indeed any lipid-lowering therapy, and monitor that accordingly. Again, are there any particular targets in relation to what the non-HDL should be? NICE guidelines adopt the same rationale that they adopt with every primary prevention, so a drop of equal or more than 40% of non-HDL would be applicable. My view on the topic of lipids is that low lipids really do not do any harm according to evidence. So the lower we can get them with a regime that is acceptable to the patient, then the better. Of course, the question is, what about my patients that have had atorvastatin and they can't tolerate their atorvastatin? We can try with other statins as well, such as rosuvastatin. in case that statin is not the one for them, ezetimibe does not have any contraindications to its use in the CKD population, provided that we have an eGFR again more than 30. And then the newer kids on the block, when it comes to things like bempedoic acid, ezetimibe, a sort of similar approach there as well. For the secondary prevention, obviously, we are aiming for an LDL of less than 2. And that's CKD or non-CKD. Again, there's no real signal anywhere to indicate that any injectable therapies in terms of lipid management have any benefit in patients with CKD unless they are on dialysis. So we spoke about our patient, Mr. Ali. We spoke about how we could potentially manage him. We've talked about the fact that maybe we need to start thinking about adding an SGLT2 inhibitor at this moment in time. We could do with increasing his ramipril as well before we add any other agents to see whether we are addressing the proteinuric element. And I would suggest that given his profile already, that we repeat those bloods, especially for kidneys, actually in around a month's time, because we have changed his ACE dose to see what the trends are. We've added atorvastatin as well, and then I put the ibugel 5% gel on purpose. There is a lot of fear about non-steroidal anti-inflammatories and chronic kidney disease. And indeed, NSAIDs and chronic use of NSAIDs is one of the leading cause of chronic kidney disease from an iatrogenic point of view. However, when it comes to a balanced consideration of risk versus benefit, and we've got a patient that's already taking paracetamol, already takes the occasional coconomol as well, and still complains of pain, I would say that if we are to go down the route of NSAIDs, the use of topical NSAIDs, particularly in patients that are not CKD stage 4, would be applicable. You would say, what about the patient on dialysis? Dialysis is a very different kettle of fish because in anuric dialysis, in reality, their kidneys have been taken over by the dialysis machine. So in reality, whatever medication you give to someone, provided that they will be dialyzed, that makes a huge difference. That doesn't mean by any means that I'm suggesting that please give naproxen 500 2 times a day for 6 months to anyone with chronic kidney disease, but I'm talking more about the patients that we see on a day-to-day basis, where really the NSAIDs would be a pitfall. Commonly, would we give a short burst of NSAID to someone with CKD stage 3A, A1? Ideally, we shouldn't, but again, everything comes as a risk-benefit discussion that we have with our patients. And I believe us in primary care, what we are excellent at doing is providing personalized care. And I'm not here, like I said, to preach the gospel of only renal protection. I think we have to be realistic with what the patient wants and what the patient is asking, and really what his quality of life is all about. Because, as we said, high blood pressure, kidney disease, they're silent. Adding another 2 medications and 1 more capsule to him to take, that's not silent for him, that's more visible. So a lot of the times it's about having that educated discussion with our patients and explain why we do what we do. Any questions at this point?
I can't see any in the chat at the moment.
Fine. So Sheena, that's when now I will really need your favor, your help. Sorry. Next, I've got 4 quick fire questions. We would give around 45 seconds for each quick fire question, and just single word answers of what you would do to the patients in front of me. And Sheena, if you could just summarize, let's say if there was anyone that said refer, say we had a lot of referrals, that sort of thing.
Okay.
So I'm going to start with our next patient. So 68-year-old male, CKD known 3A. He's got that drop in his eGFR 54 to 39. We've now done his urine ACR 85. His potassium is a bit high. He's on 3 medications for his blood pressure. His blood pressure is still high. what are we thinking there? So 45 seconds, and then I'll ask Sheena and Luis for a quick summary.
I think we're getting our 45 seconds up. Or
Well, we can sum it up. If we have a lot of similar answers, I'm happy.
I think they're all happy to refer that one.
Good. So, and we'll come back to this one in a bit. But I sense a lot of sensibility. So our next patient, 59-year-old lady, just comes and tells you, doctor, I felt tired. And you dip her urine in practice. You find the hematuria. You find protein as well. You don't find any signs of infection. And then you say, you know what, let's do a urine ACR tomorrow morning as well and your blood tests. So let's give it 30 seconds now. And our 30 seconds are up. And what was the consensus?
I think this is another refer one, actually.
Fine. As I said, there's a lot of sensibility in the room. And then we're going to our 75-year-old gentleman. So type 2 diabetic, those are his numbers. I want you to tell me more than anything what you would do and why. So this is one word about what you would do and a couple of words, what you would do, and then a couple of words about what you would do, sorry, and then why, just another word as well. So just a sentence, really. So for this one, because it's two-part, 40 seconds.
Okay, so I think there's a variety of thoughts about investigating the iron deficiency anemia. So probably a fit test and depending on maybe a 2-week wait colorectal, but also just to be aware that this could be a presentation of myeloma.
Good. So all of those are right answers, and this is actually something that we could definitely see in practice. It makes perfect sense to do a myeloma screen, makes perfect sense to do a fit test, makes perfect sense to test for hematuria as well. Any other causes that we may think that may be causing this presentation that would indicate that maybe we need to do something at this point? Once we're happy, by the way, and I completely agree with all of us about excluding cancer. So once we've excluded cancer safely, what do we think the next steps could be? And the hint is that this is a kidney talk.
Yes. Well, there have been some suggestions that maybe we should check his blood pressure as well and probably refer him to nephrology.
Absolutely. So the reason why if indeed this patient doesn't have myeloma, doesn't have bowel cancer or indeed any other cancer, and we are lucky enough that we do have now rapid diagnostic services, albeit with the eGFR of 27, maybe a bit more limited, but iron deficiency anemia and anemia of chronic disease are both very, very common in patients with chronic kidney disease. In reality, we wouldn't expect to see it in our CKD stages 3A, 3B, but it starts creeping really once we have our patients with CKD stage 4. So absolutely right. We need to see what his blood pressure is doing. We need to see his medications. And then because he's now potentially started developing not side effects, but complications of the chronic kidney disease, it would be time to start thinking about having a chat with our colleagues in secondary care. So, and now our final quick fire question. What would you do with this lady? This is part of her annual screening, her annual review. Anything that you would do about this lady and her HbA1c, just as a covering point. It's not there, but let's say her HbA1c is 53. And what's the consensus?
I think obviously this is probably going to be somebody that we wouldn't refer, but you'd need to work out her KRE thing, isn't it?
Absolutely. In full agreement. This is actually exemplifying that we've actually done everything right so far, but we need to check exactly as you said, her KFRE, in order to risk quantify the next steps that we may need to take. And indeed, the reason why I did these 4 quickfire cases is because A, they're relatively common, and B, they're a good example of the situations where we need to start thinking about referral. 5-year KFRE predicted risk more than 5%. I would actually make that one of the first ones to think about, because those are the blood tests that we see. Those are the patients that we just see blood tests of when we find bloods, for example, that we've never seen this patient. So having the KFRE in the back of our minds is an excellent point. Obviously, severe albuminuria, very, very important to be referred forward, and albuminuria with hematuria. Complications they are thinking about, could this be nephritic syndrome? That's somewhere we need to have a chat with our nephrology colleagues. Any sustained decrease of eGFR more than 25 or a change in eGFR category within 12 months, and that is an example of our very first case, would be a situation where we would need to start thinking about involving our primary care, our secondary care colleagues. And that's a similar thing with a sustained decrease of eGFR of more than 15 within a year. Patients that have poorly controlled hypertension despite being on 3 or 4 medications. Cases where we're thinking about any structural causes of disease. That's the point where we would refer. And now, KFRE, and why I keep on banging about KFRE. We all know about Q-risk, whether we believe in it or not, it's a different story. But Q-risk has been amended in clinical software like System 1 and EMIS. Q-risk is out there. We know that with any patient that has their cholesterol checked, we need to do their Q-risk. KFRE is really, really similar. And if anything, it's more validated with regards to the fact that it only looks at a 2-year and 5-year risk associated, rather than Q-risk that looks at 10-year risks when it's not really applicable in someone that's 35 and it's not really applicable at someone that is 82. And it has been validated in UK population, and it takes in consideration 4 things: the age of the patient, their sex, what their estimated GFR is, and their urine ACR as well. Based on that, it will give you a score, and it will give you a percentage score, actually, that shows the risk of developing the need to see a nephrologist or the need to be on dialysis over the next 2 or 5 years. And where the risk to need dialysis or have any severe deterioration is more than 5%, that's the point where we would think about including secondary care early. And in reality, the patients that you will pick up a lot with this is those ACRs that are a bit raised with a relatively decent eGFR that otherwise we wouldn't bat an eyelid, because as we said, eGFR is filtered, but it's leakage that signifies that the damage now is getting to a point of worry. And the good thing about KFRE is that it objectifies the risk. It actually is something to have a chat to the patient about in terms of images and indicating to them what the risk is. And it protects the patient, but it also protects us if we add this extra step. Unfortunately, at the moment, this is not inbuilt in any system that I'm aware of. But if you just write KFRE UK on Google, it will come, and literally you press KFRE calculation, you just put the numbers in, and it does so. It doesn't record any anonymous, any information that is sensitive. You could even have a play with imaginary patients like the patients that we've just talked about, and it doesn't store any information, any sensitive information at all. So this is an image of an imaginary GP practice somewhere in England, and the reason I've included this slide is a reminder of, we've talked about all this and about individual patients, and obviously individual patients are at the heart of what we do. But what about the practice, and what about the practicalities of everything we said, and why does CKD matter to us in general practice? In reality, unfortunately, we're not that incentivized from a cost point of view in terms of CKD. The only expectations that we have are to have a CKD register and then check the people's EGFR annually, and their ACR. It's important that the CKD is mentioned in 3 COF points, one looking into smoking, one looking into cholesterol, and one looking into diabetes. But even in the new contract, for the ones of you that had, in inverted commas, the pleasure to review, you will see that there wasn't really any change in terms of COF and CKD monitoring. But as we've already mentioned, monitoring CKD, acting on CKD, really prevents us from a lot of later on hassle when it comes to managing patients, because in reality we need to treat CKD as a very important risk marker. And now it wouldn't be a chat really without talking a bit about the evidence. And I wanted to talk about STOP-ACE, which was a study actually that happened in the UK. And it's not common that we have studies relevant to renal care in the UK. And it was actually done in the north. It was based in Birmingham from a study support network, but it was actually conceived where I did my PhD. It was conceived in Hull by Sanil Bandari. And essentially, we always have this fear about ACE inhibitors, ARBs, in terms of EGFR and what to do with it in any patient with CKD, and when to start it, when to stop it. And what they did, they actually took patients with quite advanced CKD. So we're talking about CKD, median EGFR, 18, so CKD, good CKD stage 4. And then they randomized them to continue or discontinue ACE inhibitors and ARBs. And what they found out is that there was no improvement in EGFR in the arm where the ACE was stopped. And indeed, there was more end-stage kidney disease in the patients where they stopped the ACE inhibitors or the ARBs. There was no cardiovascular benefit in doing so. And then what it means really for us is only stop them permanently, not when we talk about the sick day rules, for only clear-cut indications. So the patients where we have refractory hyperkalemia, the patients with symptomatic hypotension, the patients with repeatedly acute kidney injuries. And the important thing is that this trial gives us confidence when it comes to ACE and ARB inhibitors. And in reality, it reminds us of the fact that there will be a transient decrease in renal function when we start an ACE inhibitor or an ARB. But indeed, we should be looking at creatinine and be looking and inspecting whether the creatinine really either goes higher, more than 50% of the starting creatinine, or indeed whether it goes above 266. You'll tell me, Zen, what if I start already with a creatinine of 275? In that case, I would say, depending, of course, on what their EGFR is, and don't forget that according to guidelines, we shouldn't really be starting an ACE inhibitor out of our own accord in a patient with an EGFR less than 25 without chatting first with our secondary care physicians. But even if we start, and in that case, I would advocate that we monitor a lot their potassium and also that increase in creatinine of more than 50%. The other thing that I mentioned is, of course, about the EGFR, what happens with the patient's EGFR. In reality, if it doesn't increase more than so it decreases more than 25%, or it doesn't jump stages, then I wouldn't necessarily be worried. You will tell me, but what about the one that's between 3A and 3B? What I would say is from 3B, but it was very close change. Repeat the investigations in 1 to 2 weeks and monitor the trend. The other important thing to always think when this change happens in patients is to make sure that there's no other cause for an acute kidney injury to appear. No concurrent medications, more importantly, NSAIDs, which is what we've talked already about. No other infections, no volume depletion, anything else that could be happening in the background that would just with the starting in someone. It was that someone with CKD and no hypertension, no diabetes. What I would say, I would start probably at the lowest dose possible. If it's Ranipil, 1.25, if it's losartan, 25 milligrams, and I would only escalate if there was no positive trend in terms of their proteinuria. I would take it slow, I would take it steady. Reason being, not only we don't have any, not only we are not the specialty looking after kidneys, but also because we have to think about our capacity in terms of bringing patients in to be retested. Now, the future, we've talked about SGLT2, and now one comes and talks about GLP-1s in clinic, but also finerenone, which you may which is this is easy. I don't need to memorize any dates or anything like that. It's important for it to be busy because it backs up the notion of rigorous evidence supporting the use of these medications in multimorbidity. If we looked at medications such as studies, credence, kidney, these are studies with composite renal outcomes, and these are studies which included over 16,000 patients with CKD stages 3, which really is what we see in general practice, our bread and butter. We know already that SGLT2 inhibitors are part of the 4 pillars of heart failure management, especially heart failure with reduced cardiovascular events. The FLOW trial in 2024 of semaglutide, it looked at type 2 diabetes and chronic kidney disease. And what it indicated is that the use of semaglutide, independent of whether we're using RAS blockade or not, significantly reduced the risk of major kidney composite outcomes. So that's kidney failure, a drop of eGFR more than 50%, and anything that leads to renal or cardiovascular death. So finerenone, as I said to you already, a non-steroidal MRA, it has had a number of studies, Fidelio DKD and Figaro DKD, and they put the evidence together. What it showed is that in patients with diabetic kidney disease and proteinuria, there was a reduction in both kidney disease progression and cardiovascular events. And that highlights how finerenone can be used in these patients. For the interest of time, we shall move forward because a very important thing is actually what do we tell to our patients. And I used to say, I don't know how many of you use AccuRx's, and we had a pre-populated AccuRx in my clinic, in our practice, which said to the patient, we've done your bloods, you have CKD stage 3A, this is some information about it, book an appointment to speak with your doctor or another healthcare professional. And I've had patients coming to sheer panic, talking to me about CKD stage 3. Thinking about stage 3 and cancer. So the language we use for our patients is very, very, very important. And a lot of the times, the way that I want to speak to patients really is really of medical background. And I always describe kidneys as the filter that cleans the blood. And I always explain to them that all those blood tests show is just that the filter they're slightly weaker than what it should be. But that is something that can happen with age, with high blood pressure, with diabetes. And that's why it's important that we slow the impact of those diseases on you in order to keep you healthy. They might always ask me, but doctor, I don't have any symptoms. That's where I tell them kidney problems will only give you symptoms if kidneys were severely harmed. And that's why it's important that we do those blood tests. And then I always end up with a positive in that the majority of patients with CKD will never need dialysis, provided that we are proactive and that we take good care of all the risk factors. I always enjoy giving to my patients a lot of information in terms of where they can find information. And I would say that when it comes to patients, Kidney Care UK is excellent. It's excellent to talk about diet. It's excellent about information leaflets, but it's also excellent for podcasting. We are entering now younger generations that because of metabolic syndrome do have an element of CKD, that they would benefit from listening to podcasts, for example. With regards to us in healthcare, the UK Kidney Association has an education hub which is CPD based, and so does the RCGP, but also the e-learning for healthcare provides CPD accredited modules on CKD. Finally, for those of us that do enjoy listening to podcasts, the Northwest London Integrated Care Board and Imperial College Healthcare NHS Trust does the For Kidney's Sake podcast, which is run by two excellent renal physicians who talk about everything kidney related from what the management involves to actually common questions that patients come up to speak to us about, such as supplements, anything related. I would highly recommend it to anyone ago. So that's it from me in terms of kidney diseases. And that was really a quick whistle tour, even though it did take an hour, but it reflects to the complexity of what we see in front of us. I just wanted to really highlight that CKD is common, but it's manageable. Albuminuria is what drives the risks. And then that it's important for us to address all the risk factors that we talked about already. SGLT2 inhibitors, really, they are nephroprotective as well. And in reality, a lot of CKD can be safely managed in primary care, and it's what we do every day. We manage uncertainty, we manage chronic disease, and now more than ever, we have a lot of things in our arsenal to help us in a structured fashion address CKD. Before we open to questions, I need to do a bit of shameless the Primary Care Multimorbidity Society, Primary Care Cardiovascular Society. We have ample and interesting modules in terms of cardiovascular disease and cardiovascular care, which are CPD accredited and are for free. So membership is free. We have our podcasts on Spotify for those of us that are quite busy and they try to do some of their CBD while driving to work. And as a nice indicator already of what we were talking about, we've launched our first PCCS Multimorbidity Conference, which is in Birmingham this year, 26th of March of 2026. It's free to attend. And again, any of you that want to attend, by all means, please feel free to take this as an invitation. Important to mention, it's free at a reputable location with a lot of reputable speakers as well. So thank you so much for all the patience that you've shown for this presentation. And I'm happy to take any questions that we may have.
I think thank you very much for that. It was really sort of practical advice and lots of helpful resources there. And I think we're all taking a picture of the QR codes there. So it was just an excellent talk, really fitted in well with what we had earlier. So it was really helpful.
That was the difficult bit, Sheena, because I was really, it's difficult to come after a secondary care physician to talk as a primary care doctor, you know what I mean? But in reality, I do think that we are experts in chronic disease management, and we need to, in a previous life, I was a renal research fellow. And in reality, what our colleagues see is the end game, but we are the ones that really can control whether the end game is ever necessary. CKD will lead to a significant cardiovascular morbidity, but whether we are able to give our patients a reasonable quality of life and good disease prevention, that's where it relies on us, if you see what I mean. And that's why I'm so happy to raise the flag of primary care when it comes to managing multimorbidity and chronic disease.
No, well, I think you smashed it. You absolutely nailed where we needed to be. So that was really, really helpful. I'm not sure anyone's put a question in the chat or whether anyone wants to put their hand up at this stage.
But also, if people want to drop me a line as well, I'm sorry, I'm going to give all of you a vertigo after this with me changing the slides. My email, both my HIMSS email, so my medical school email, but also my LinkedIn, and also my email is there as well. So anyone that wants to have a chat about something, it won't be obviously a medical legal advice per se, but it would be anyone that wants to have a chat or anyone that wants to ask about any useful resources by all means.
That's really kind. Yeah, I think everyone is so difficult, isn't it, now with the new contract? I think everyone's conscious that they've got to go back and do work. But thank you so much for your time. We will get some feedback from you as well, but I can already see people giving you thumbs up and writing thank you and great talk in the chat and things. So we will give that to you. But Zen, that's been so kind and so useful. I really feel like I'm more on top of it now than I've been for a long time. So.
CKD is difficult, and the guidelines aren't easy. I tried to make it a bit easier to follow, but I remember going through them myself and having to scroll between points. And I hate when that happens because A, we're very, very busy, and B, you can't have the patient in front of you. Scrolling, yeah, just a moment. I'm scrolling. Yeah, so albuminurias, but what about the blood pressure? But okay, but what about the diabetes? And I think that's where the new guidelines in terms of diabetes are better, in that for the first time, and I'm proud to say that within the UK platform, NICE has actually provided us with guidelines instead in terms of chronic disease that are very easy to follow in terms of multimorbidity as well. Obviously, the COPD ones were very, very helpful, and it's because BTS was very involved in those as well. But I think when it comes to this sort of multimorbidity, the new diabetes guidelines really finally untie our hands a bit.
Yeah. Yes, and we are hoping that we will have a talk on frailty. We're just trying to confirm that. It might change on the 23rd of April, but that's our next PLT event. So multimorbidity will still be in our mind then, I think, but we've all got a lot of learning there. But thank you, and I'll let everyone get away, but please make time to give some feedback. I know you might have to scroll up the chat a bit to get the QR code, but we would really appreciate the speakers would appreciate, and we as the training hub would really appreciate your feedback. Thank you, Zen, again, really kind.
No worries. Shall I put the feedback form on again? Not the feedback form, sorry, the other QR codes up again as well for, yeah, sure. I might as well just share that as well, and then.
Yeah, we've still got 70 people online,
exactly. So I might
we've lost a couple, but not many.
Yeah, so we've got it there, and then I'll keep on rotating between the two.
Are you speaking at Birmingham on the 26th?
No, I'm not speaking in Birmingham at all. I wish I was, but I'll be there, of course. And yeah, it's an interesting, to be honest, since we still have to, it's a very interesting agenda. It doesn't focus so much on CRM as you would want, really, and this is something that we will be addressing, but there is a lot about women's health. There's a lot about cardiorespiratory, so we just talked about COPD. There is about frailty. There's about mental health as well. So it's really, it is talking about the heart a lot, but it's actually looking at them from the heart point of view rather than talking about the nuances within the ESC guidelines or the American Heart Association guidelines, and it's a very relevant agenda. And then obviously our big conference in May, I am speaking in that one. But again, a lot of it is not so much about the what, it's more about the how, because in what we do in primary care really is the how. It's not so much the what. And by how I mean from how we speak to patients to how we go on the pathway with them of disease, to how we modify medications, as to what we know best in terms of evidence, but also as to what we know that fits the patient. So yeah, the one thing I like about PCCS is that they're quite pragmatic and they understand that we are GPs, if you see what I mean. We are primary care providers. It's not cardiology driven or anything like that. And I'll scroll again up.
Yeah, no, I think I'm already looking at my diary to see if I could move things around for the 26th. So maybe see you there.
Absolutely, it'd be a pleasure.
Okay, I think people are starting to drift away now, so then I feel we should let you go as well, because you've been very kind with your time.
No. Honestly, it's been a pleasure. Like I said, I'm very passionate about this kidneys, but also CVRM, and yeah, it was a pleasure to come and have this chat with all of you. And I want to thank everyone obviously for the interaction, even though it can be difficult over Microsoft Teams. But again, I think people did interact, and I'm appreciative of that.
Yeah, we've got a good audience. That we've got used to Microsoft Teams, but at least it does make it possible to attend, even if you've got